All right. Welcome to Unit 26. Today we are going to be talking about medications that are used to help treat disorders of the endocrine system, which pretty important system. And how we're going to go through it is we're going to start with the base of the system and kind of work our way out. So the master gland, the beginning of our endocrine system, is the pituitary gland, which is located at the base of the brain. And basically what it does is it regulates the endocrine system. It's kind of the big boss, the master gland that figures out how our body's going to run. It's kind of the brain of the endocrine system. It secretes different hormones, and when you get too many of those hormones, you can get something called giantism. That is if it occurs before puberty, and that's where someone is extremely, or I shouldn't say extremely, but oversized in all features, in height and head size, hand. It's all in proportion. It's just someone's much larger than normal. If it occurs after puberty, it's called acromegaly, and then it really only affects the hands, the feet, the things that still grow after puberty. Those things will continue to grow and get abnormally large, whereas the things that stop growing will stay the regular size. So it's giantism's pre-puberty, acromegaly is post-puberty. Usually the only reason you have overproduction in the pituitary gland would be because of a tumor, and that would be treated like any other cancer with radiation, surgery, or chemotherapy. On the flip side of that, we would have the underproduction of the hormones that come from the pituitary gland, and that would result in a lack of growth or dwarfism. It also can result in poor function of the other glands in the endocrine system, leading to other problems. And generally, how we treat that is we just replace the pituitary gland hormone. There's a medication called somatropin that we use. It's an injectable, and people are followed pretty closely when they have this, but it is something that can be treated, especially if it's caught early. The next gland we're going to talk about is the thyroid gland, and that one is the butterfly gland that's located in our neck. And it basically is the regulator of our metabolism. It's kind of the governor that figures out how hot we're going to burn, what kind of energy intake do we need, just kind of overall determines the speed of our metabolism in our body. It is regulated by the pituitary gland, and it does require iodine to function. You may have heard of the fact that all salt in the United States is iodized salt. And the reason for that is that when you have a lack of iodine, you can get something called a goiter, and it's completely preventable if you get enough iodine in your diet. So they started putting iodine in salt, and goiters essentially went away. With the thyroid, you can have, again, too much, and that is hyperthyroidism. It is also called Graves' disease. And the way I think of it is it's kind of overrunning the metabolism of the body. So it's using up a lot more energy than it should, results in weight loss. It's that typical picture of someone with really buggy eyes. They're always cold. It's one of those things where and they're jittery. They have an excess of energy that they can't quite get out. And so it's just the body's in overdrive all the time. And the way we can treat that, there's a couple different ways. One would be surgery to just take the thyroid out. Sometimes they will do radiation to actually kind of kill part of the thyroid to try and encourage it to produce less. And then there's also actual medication that can be taken as well. The most common one that I see is methimazole. That medication can be taken orally, and it is taken daily, and that can help to basically kind of rev back the thyroid gland so it doesn't work so hard. But how they choose to treat it kind of depends on how extensive the problem is and what patient preference is. The good news is let's say you chose to have surgery or radiation and it just completely killed your thyroid. We do have replacement thyroid hormones, so you could live that way. Also, if you had a lack of thyroid, hypothyroidism, which doesn't have a funky name, that one is where you don't have enough production of thyroid hormone. And when you have that, you can result in a condition. There's one called myxedema that occurs in adults, and then when it occurs in children, it's called cretinism, and essentially it's just untreated. It's a lack of thyroid hormone, and it's kind of opposite of what Graves' disease is. There can be an excess of weight. People are constantly hot. It's just basically the body is not working as hard as it should to keep things moving. And how we treat that is just replacement hormones. There are synthetic hormones that we make that people can take. There is, in this situation, a medication that is from pig thyroid gland that people can take in a pill form. You don't actually take the gland. That'd be kind of gross. And then there are also basically two kinds of thyroid hormone. There's T4, which is the kind that you store and kind of is your bank. And then the T3 is the active version of the thyroid hormone, and T3 gets used up very quickly. And so sometimes when you look at someone's problem, it could be with T3, it could be with T4, it could be with both. And so there are different ways that we can treat it. But essentially what we're going to do is we are going to go ahead and replace those thyroid hormones so that the body functions at a normal rate of metabolism. So on the outside of the thyroid glands, we see these tiny little pinhead glands called the parathyroids. They secrete a hormone called parathormone, and it regulates our calcium and phosphorus use in the body. A deficiency could be due to a genetic defect, or possibly surgery. If, let's say, you have to remove the thyroid hormone or the thyroid gland, you'd probably miss the parathyroids as well. And what that will result in is a loss of calcium and not effective use. And that actually can affect a lot of things, including our neuromuscular system and also actually our brain activity. And so a lack of parathyroid hormone can actually lead to psychosis issues or psychiatric disorders. And we treat that with calcium supplements. It's actually pretty easy to just give people enough calcium to keep them regular, and we can treat that. Next down, we have the adrenals. These guys are important. They're little glands that sit on top of our kidneys, and they are regulated by the adenocorticotropic hormone, or ACTH, the pituitary excretes. And the adrenals actually have two parts. They have an outside part and an inside part. So you have the cortex, which secretes glucocorticoids, mineralocorticoids, and androgens. And androgens are going to be the sex hormones. And then if you go to the medulla, we are actually looking more at neurotransmitters like dopamine, norepinephrine, and epinephrine. So that kind of is in charge of flight or fight response, communication in the brain, lots to do with the neural pathway. The kidneys actually the adrenals do a lot of hormones to help regulate our metabolism. They also help with, when you look at the androgens, secondary sex characteristics, and basically, these guys are important. And you may have heard of something called adrenal fatigue, where people they overstimulate the medicines the hormones that come out. And there is something called Addison's disease, which is a situation where it's not so much that you overuse the adrenals, it's that the adrenals start to decay or change. So they can't secrete the hormones like they normally would. And that Addison's disease is an interesting one because people end up with copper-colored skin. And so that's kind of the hallmark of Addison's disease is someone's the skin color. And essentially the body, again, is kind of overworking itself in the fact that you get weight loss, weakness, possible dehydration. And how we treat Addison's disease is we actually will replace those steroids or hormones that are coming along to try and compensate for the insufficiency, the lack of the um, hormones that are coming out of the adrenals. Kind of similar to that is when someone uses steroids or adrenal cortical hormones for a long time. So let's say someone is on a high dose of prednisone long term, they can get something that's called Cushing's syndrome. And essentially what that does is when you give steroids to the body long term, the adrenals kind of go, oh, okay, I don't have anything to do, so I'm going to stop producing stuff. And then the body compensates with a variety of problems. And what can happen is you get increased fat deposition in like the face and the extremities. So it gets something called the moon face. You can get weakening of the bones. It can interfere with the menstrual cycle. It can cause edema in the extremities, so you get really puffy in the feet and the hands. You can get extra hair growth, the hirsutism, so women are sprouting beards, and it can actually cause the skin to turn kind of purple. So that's, if you ever wonder why people or why doctors want to limit steroid use or like prednisone use when people are feeling sick, is because of that, because long-term use can actually result in Cushing's disease, which is not fun. All right, we're going to go kind of back up to the center of the gut and talk about the pancreas. We love the pancreas. The pancreas is awesome. It has the islets of Langerhans, which secrete insulin. Insulin makes sure that we can metabolize the food that we eat, including fats, proteins, and mostly carbohydrates. So when it secretes insulin, essentially what happens is insulin will increase a cell in the body, its sensitivity to let glucose in. So we are able to take the energy that we eat food, it gets metabolized, it gets absorbed, and then eventually becomes glucose. And then the insulin says to cells, hey, I've got some energy for you, take up this glucose, and it'll take the glucose up and store it. So when we don't have enough insulin, we can't metabolize the glucose the way we need to, and it ends up hanging out in our bloodstream. So if we have too much insulin, we're in a situation called hypoglycemia, meaning all the sugar is like sucked up by the cells and we don't have any sugar left to use in the rest of the body. If we have low levels of insulin, then we have too much sugar floating around, and that's called hyperglycemia. These are both situations that usually result from being diabetic. Diabetic is essentially, if you're type 1, you don't produce any insulin on your own. Your pancreas does not produce insulin. You don't have a pancreas. There's one of the situations results in the fact that you cannot produce insulin, so you do not effectively metabolize sugar and get it into the cells the way it needs to be. A majority of diabetes these days is type 2. And that is one that we develop over time, and we develop what's called insulin resistance. Essentially what happens is the cells, whereas let's say one molecule of insulin could tap on the cell and say, hey, take this glucose, and the cell would go, okay, and it takes the glucose. Insulin resistance is one will knock and say, hey, I have glucose, and the cell's like, I don't care. So then 2 things of insulin have to come by, and then 2 are knocking, and it's like, oh, all right, fine, I'll take the sugar. And then as it progresses, you take more and more insulin just to uptake the same amount of sugar. And that eventually results in the body, the pancreas, overproducing insulin, tiring itself out, and usually eventually ends in the pancreas not functioning properly at all. So when you are looking at diabetes, and this is diabetes mellitus, not diabetes insipidus, the most common one is going to be the type 2. Okay, and that one is preventable. And that one, sometimes you need to use insulin, sometimes you don't, and we'll talk about that. And then the third type of diabetes is one that can happen when you're pregnant. We call that gestational diabetes. And people can sometimes develop that during pregnancy, and most of the time it usually goes away after birth, though sometimes that is not the case. But that one is usually just temporary. But type 2 is the one that we're going to be highlighting on. And The spotlight in this particular chapter is all about diabetes. And I will tell you that that is probably that high blood pressure and high cholesterol, top three things I see out there. And so to understand how to treat diabetes, how to help patients, I think is really important. They also talk about risk factors. You know, I talked about diabetes being preventable. There are things we can do when people are heading down that road to try and help them from overtaxing their pancreas so that they don't become diabetic. They can be pre-diabetic and then go back to a regular state. But once they become diabetic and once that the pancreas is just overtaxed, a lot of times it's hard to go back. So when we're talking about diabetes, essentially we're talking about a lack of insulin. So one of the ways we can treat it is to replace insulin. And so we have found a way to make artificial insulin. And what that does is it encourages the cells to take the glucose into the cells. And we obviously need it to live. And that is the primary treatment for type 1 diabetes. Type 1 diabetics just don't produce insulin, so the best way to treat it is to give them insulin. It takes some really heavy monitoring. A lot of type 1 diabetics that I've met or at least had interactions with tend to have an insulin pump where it's pumped in their body throughout the day, or it takes really extensive testing 5 or 6 times a day to make sure that they're getting the right amount of insulin to maintain good metabolism. Type 2 diabetes, insulin is not firsthand. That usually will come down the road if someone is not being able to be managed on oral agents. Then we'll usually turn to insulin. And I think the reason we don't jump to insulin right away is because it is an injectable and it is rather expensive and hard to manage. And then we can also use insulin to treat ketoacidosis. Like I just said, we can't do insulin orally. It's a structure is too fragile to survive the acids that are in the stomach. So we have to, at this point, inject it. There was a inhalation insulin that came out a few years ago. It turned out not to be as stable or effective as people were hoping, so it's not around anymore, and we're essentially back to injections again. We have different types of insulin out there. We've got rapid acting. The rapid acting is the ones that you use like right before a meal to try and regulate your blood sugar from eating the food. The long acting we use to try and regulate blood sugar, usually it's overnight. So it keeps people from going too high overnight while they're sleeping. Or sometimes it's enough that if you can do the long acting, then you don't have to do rapid acting with each meal. It kind of depends on the situation and how people are being treated. But before we go to insulin, if you're a type 2 diabetic, chances are you actually are going to start with an oral medication. There are multiple types out there, but the first two have been around for a long time. The sulfonylureas actually stimulate the pancreas to make more insulin. So we talk about how the body is resistant to insulin and needs more. So this, what the sulfonylureas do is they encourage the pancreas to make more insulin. Now this is making the assumption that the pancreas is working and can make insulin. So obviously for a type 1 diabetic, this isn't going to do anything because their pancreas won't make insulin no matter what you do to it. But in this case, if you have a pancreas that's just a bit sluggish, you can encourage it to make more insulin. With this, low blood sugar is can be a pretty common side effect. People need to make sure they're eating regular meals, and you start on the lower end of dosing and kind of work your way up to make sure that the blood sugars stay where they need to. And this medication, essentially, it's kind of more of a secondary line. The first thing I usually always see people on is a biguanide. And so the sulfonylurea, the one that should kind of stick in your mind is glipizide. With the biguanides, it's metformin. That's really the only one I see out there these days is metformin, and it's a generic. It's relatively inexpensive, and it actually has a twofold process. It can actually help the liver to make or release less glucose into the body, which we don't need an overabundance of glucose. That's what happens when we're diabetic, because we can't take up the glucose we eat. We start to get too much blood sugar, and the liver just happily releases glucose because that's what it does. And this tells the liver, hey, stop, don't release any more glucose. And it also increases the sensitivity of the cells to the insulin. So instead of, we were talking about needing 2 things of insulin to make the cell go, okay, I'll take the sugar, this may make it so that it only needs 1 unit of insulin to get the sugar. The biggest problem that I see with metformin is hypoglycemia. What happens is most of the time it's usually because people don't eat enough, or because they have forgotten to eat a meal, but they went ahead and took their medication. And so when you put less sugar in your system from the liver and the cells are gobbling up all the glucose out of your body, it can drop your blood sugar level pretty quickly. So we do need to be careful with this one. And I do always encourage people, if you're going to take your metformin twice a day, do it with your meal so that you know you're going to eat, because you don't want to be in a situation where you haven't. More recently, we've had other medications that have come up. I do see quite a few people on this medication. I thought I had it. Thiazolidinediones, or pioglitazone, as I like to call it. There is more than one of these guys, but pioglitazone or Actos is the one I see most often out there. And essentially what it does is it increases the cell sensitivity to insulin. So again, you only need 1 insulin instead of 2 to get the uptake of the glucose. It's can help with insulin resistance. But this one, I think the hard part about this one is it can induce some weight gain. And people generally shy away from medications that do that. But it really can help with blood sugar. So it's one of those where you kind of got to weigh the benefits and the risks and see what makes the most sense. You may notice that there may have been some advertising about the pioglitazone Actos and bladder cancer. It's more recent medication. We don't know what the long-term consequences are. There is a situation where people can, go and talk about the safety issues. Anything beyond metformin and glipizide, I think we are taking some risk in treating diabetes because these medications haven't been around as long. But we do know that if you treat diabetes, you will live longer. And so these associations with medication and extreme side effects, I always want to be like, just educate yourself before you make a decision one way or the other, because you have to look at, yes, it increases my risk of this type of cancer, but I will also have a good quality of life for the next 20 years if I don't get that cancer. So something to think about. All right, these classes of medications are definitely more recent. And so the alpha glucosidase inhibitors, these are ones that essentially keep the glucose from being absorbed out of the GI tract. And so it delays the rush of glucose into the body after you eat. So it keeps the blood sugar from spiking. I don't see it used as often. I think mostly because it has to be taken before each meal. And it really only helps with the glucose absorption. It doesn't do anything with the pancreas or the actual sensitivity of the cells to the insulin. So it can be used, but I don't see it quite as often as maybe some other items. The maglitide, I'm having a horrible time, you guys, right? All right, the maglitinides help to increase insulin production. They stimulate production of insulin in the pancreas. The example of this one is repaglinide. These guys are great if you have a pancreas that is functioning enough to be encouraged to make more insulin. So again, it kind of depends on where you are in the progression of your disease, but this may be helpful if your pancreas is still working. Then we have the dipeptidyl peptidase 4 inhibitors, or DPP4 inhibitors. That's usually how you're going to see them referred to because that's a lot to write out. These medications help to decrease the production of glucose in the liver. Our liver actually can produce quite a bit of sugar, and we can help to decrease our blood sugar levels by stopping the liver from making those. And the most common one I see is the sitagliptin, or it's also called Januvia. You may have seen a commercial for that one. And it helps to also increase insulin made in the pancreas, but the big thing we look at is the decreased production of glucose in the liver. And the last one the book highlights is the glucagon-like peptide 1 receptor agonist. This medication is also known as Victoza. It's liraglutide. This guy is kind of interesting. It kind of has a multifaceted approach where it helps the pancreas to increase its insulin production. It also decreases the amount of glucagon that is produced, and glucagon essentially helps to store sugar and make fat, and we don't want that. And then it also helps to decrease appetite by slowing stomach emptying. So sometimes people actually even lose weight on this medication. And so this is one I've definitely seen coming along more and more. So far, these are only available as injectables, and they have hundreds of dollars in cost each month if someone's going to be on them. So it's not something you're going to see as a first-line agent for anyone being first diagnosed with diabetes, but I do see these as probably a more common addition as the price becomes more affordable. And also the patient has to be willing to do injections. But the fact that it is associated with weight loss really does seem to encourage people to continue the use. And weight loss generally leads to better health with diabetes. So it's kind of got a good things all around, essentially. I think the hardest thing is that you do have to inject it, and the cost is sometimes prohibitive for people. All right. The last thing we're going to talk about is hyperglycemic agents. When diabetic patients get into a situation where they're trying to manage their blood sugar and it goes too far or way too low, if it's low but not too low, we can treat it with sugar or glucose. So there are things like glucose tabs, or there's like a gel, or sometimes even it's just drinking some juice or something can help to bring the blood sugar back up. But there are also situations where the blood sugar may be so low that the patient can't function to the point of being able to take those agents, and so then we use an injectable medication called glucagon. And what that does is it's basically a medication that stops insulin from doing what it's supposed to do, and then it allows the it allows the body to increase the amount of glucose it has floating around. And these medications has to be done as an injection. Sometimes you'll see people carrying around those kits, and especially if they're prone to low blood sugar. But a lot of times what I see is people using the glucose tabs. So that was a lot of information about diabetic medication. But like I said, out of all the things you're going to see, this is going to be one of the most common ones. So I would like you to spend some time studying those drugs, especially those classifications and what they do. And the example I've given you is the examples that I'm going to highlight if I were to test you on a name hint or on a classification. So I would study the name of the class of the meds, the example I've given you, and what they do. I think at this point, that's something, especially the more common ones, we want to know what they do. And that takes us to the end of Unit 26. I think we have 2 more lectures to go, and you guys get to take your final test. So, yay! All right. You guys have a great day. And if it's late at night and you're listening to this, I hope you have a fabulous evening.